thank you very much for inviting me at this meeting. I personally would like to thank first Professor Gamal Agmi for inviting me again to participate at the 10th Annual Conference of Chest Department of Faculty of Medicine of ASIUT. I'm going to speak about challenges of rebiopsy at lung cancer progression. Sometimes is really hard, both for doctors and for the patient to obtain consent from the patient to do the rebiopsy of lung cancer. Why? Patients always ask, why do we need to do the rebiopsy? You already proved that I have cancer. Why do you need to take another biopsy to take me into bronchoscopy again? Well, the point is we are doing this because of the benefit of the patient and of the possibility to apply new therapies. In lung cancer, things are moving around mutations all the time. And now we can find mutations in lung cancer cells if the tumor is completely tested. Why this is important for us? Because if the tumor has some kind of target we can work on, then there is a possibility to treat our patients better, and our patients will, especially on immuno and molecular therapy, will live longer and better, even in fourth stage of the disease. And practically new molecules are developing practically every few months. So for every mutation, for every receptor in lung cancer cell, I hope we will soon have some kind of molecule that can work on. And the most important are, of course, PD-L1 mutations, with the targets for immunotherapy. And for the molecular therapy, actually, the most important mutation is EGFR receptor mutation. In up to two-thirds of cases, when we apply tyrosine kinase inhibitors, we have acquired resistance to first or second generation tyrosine kinase inhibitors. And this T790M mutation, which is detected in approximately two-thirds of the patients with advanced non-small cell lung cancer with positive EGFR mutation, who have progressed on the approved EGFR tyrosine kinase inhibitors, ranges actually from 51 to 68%. So there is a benefit to this patient if we apply third or fourth generation molecular therapy to treat lung cancer. There are few mechanisms of acquired resistance, but the most important is, of course, development of bypass tracks involving other oncogens, epithelial to mesenchymal transition, which is very rare, but there is one significant thing that we also need biopsy to prove. This is small cell transformation. If you will see on that graph on the right side that actually those patients are 3 to 4% of patients will underwent small cell transformation of adenocarcinoma, either with in combination with different mutations or alone small cell lung cancer transformation. And a new sample is actually needed to be taken at progression to identify acquired resistance mechanism for molecular testing. There are two reasons. First, biopsy tissue taken at the first biopsy is sometimes insufficient to identify this T790M mutation or other acquired resistance mechanism, or there is something more dangerous than that for the patient, intratumor heterogeneity. that can affect the ability to detect mutational status via biopsy. And there is another possibility. You take the mutation from the primary tumor, you prove that it is EGFR positive, you treat the patient with the tyrosine kinase inhibitor, for example, of the second generation tyrosine kinase inhibitors, and after that, you actually killed the cells with who were positive for EGFR positive cells, but for T790M clones are multiplying, and now these clones are predominant at the tumor, and that's why the tumor is progressing. So approximately half of the patients who have acquired resistance were tested positive for EGFR T790M. And what do we need to have for diagnosis? First, current guidelines state that performing a local recurrence or metastasis biopsy at progression after tyrosine kinase inhibitor therapy is a reasonable course of action to determine the mechanism of acquired resistance. First, to obtain material for molecular testing or to see if the tumor changes its histology or behavior, and to apply targeted therapy. And early studies showed that there is no problem really with sample adequacy. Biopsy at progression in these 100 patients was possible in 82% of the patients, and among those who underwent rebiopsy, the sample could be histologically analyzed in 94% of the cases. And in the second smaller study, almost 90% of the cases had samples from biopsy sufficient for histopathologic or cytological examination. And it was shown that actually it's a very safe procedure. In 80%, in these Japanese studies, in almost 80%, the biopsy was successful, and adverse events occurred in 5.8% of the patients. And the most significant adverse event was actually pneumothorax in 2.5% of the patients, but actually in majority of these patients, it didn't require thoracic drainage. And if in this larger study of 230 non-small cell lung cancer patients that experienced progression after EGFR tyrosine kinase inhibitors, 45% underwent rebiopsy, and it was successfully performed in 94 patients. It's almost 90 in almost 90% of the patients, and the complication rate was 8.6, including 7 cases of pneumothorax, but which didn't require thoracic drainage. So it's really something we can expect this testing or rebiopsy at progression is included and specifically added in NCCN guidelines since I think 2015. This is from 2017 and on. Practically it didn't change. So we have to, at progression of EGFR positive patients, we need to do T790M testing and to do the in order to give proper therapy. So when exactly are we doing rebiopsy? First, or if the tumor relapses on metastasis or on change of tumor behavior, in order to assess renewed cancer characteristics, to apply either existing therapies on all targets or new therapies on new targets, especially in clinical trials. I mentioned already that every few months, a new molecule for treatment is registered, and practically a lot of clinical trials is taking place at the same times, and our patients will be practically good for start the treatment in clinical trials in order to achieve best tumor control. Which method we use? Actually all histological procedures, all procedures that can in which we can obtain a histological sample are good. Core needle biopsy, resection, of course, this is the best procedure, but also forceps biopsy, even fine needle biopsy, either conventional tBNA or even EBUS tBNA, is good for immunohistology and PCR testing, and also cytology samples are a little less adequate, and that's why we prefer, when we are doing rebiopsy in those patients, we prefer either needles, 19-gauge needles either in EBUS or ctBNA, or core needles if we are doing CT-guided percutaneous biopsy of the tumor, or ultrasound-guided percutaneous biopsy of the tumor. And when exactly rebiopsy has to take place? Well, following progression, rebiopsy needs to be conducted as soon as possible. However, if it's judged to be a challenge, necessary treatments such as switching to cytotoxic anti-cancer drug, conventional chemotherapy, and carefully monitoring the course should be continued until it's possible to perform a rebiopsy. Rebiopsies are performed on progressive lesions when the patient's disease progresses and the collection of sufficient tissue samples from the primary lung tumor and other metastatic lesions is determined to be possible. And while performing a rebiopsy, team coordination is the key thing. And you will see from biopsy for rebiopsy execution workflow, actually we need to first obtain where is the progressive lesion. Is it intrathoracic? Is it extrathoracic? If it's intrathoracic lesion, we have to use either bronchoscopy, pleuroscopy, closed pleural biopsy, pleural cytology in cases that when the patient is not in the condition for thoracoscopy. Then if there is a relapse in mediastinal lymph nodes, we either do bronchoscopy with conventional tBNA if lymph nodes are larger than 2 centimeters. If less than 2 centimeters, I personally prefer EBUS. If the pericardial effusion occurred as a result of tumor progression, we need to collect pericardial effusion. We need to do pericardiocentesis, but to submit that effusion, either pleural or pericardial, in cell block. That is the most important thing. When you are doing rebiopsy, even you have when you have tissue, when you don't have tissue, when you have liquid, or you have to do, for example, lymph node biopsy with a cytological needle, don't make smears. Send tissue, send this material sample as a cell block. Pathologists can analyze it much better than smears. If the lesion is in extrathoracic, first, the easiest thing, if it's in the peripheral lymph nodes or somewhere subcutaneous in body surface, then we can do the surgical biopsy. If it's in the liver, it can be done by CT or ultrasound guided needle biopsy. If it's in the bone, well, in the bone, things are not very, metastases in bones are not very good for analysis, as at least my pathology said so. But if the progressive lesion is in bone, and if there is a if the lesion can be reached with some kind of biopsy, well, there is no other way than to do the bone biopsy. So the point is, it requires the coordination of the multidisciplinary team. And this is the methodology. If the Department of Gastroenterology will do adrenal, pancreas, or abdominal lymph node metastasis, liver metastasis will do the hepatology department, but all the others are either in surgery or in respiratory surgery or in pulmonary medicine. Well, there are some cases when we have to do the biopsy void, or the patients in most of the in most of the cases, actually, the patients are ineligible for rebiopsy, either because of the poor performance status, either comorbidities, but sometimes there is that thing that we cannot really much influence on. Well, if the metastasis is in the brain, of course, we are not going to do the rebiopsy. If the lung lesion is less than 2 centimeters and you don't have proper navigational equipment, you will not do the rebiopsy. But in this study, actually 16 patients refused to do the rebiopsy, and a lot of them under physician decision. So physician either decided that patient should not undergo rebiopsy, or the patients refused upon physician's advice. So we have to take into considerations when exactly rebiopsy should not be performed. If it's too difficult for a location for safe biopsy, and if the result will not change the treatment. Of course, we are not going to do rebiopsy if there is no benefit or treatment change for the patient. But rebiopsy should be performed in every case if the prior specimens is too small for adequate tissue characterization, including genetic testing for predictive alterations. If relapse happens a long time, 6 months after a complete response treatment result, if the new tumor behaves in a different way than expected from the primary tumors, and if new molecules are entering clinical trials in the near future, and if the participation of the patient is foreseeable in these trials, and the patient has good performance status and will be eligible for those trials. Well, we always have to weigh the risk-benefit ratio in this rebiopsy consideration. Procedural complications as intrapulmonary hemorrhage and pneumothorax are the most common complications, and pneumothorax is usually in all available studies resolved spontaneously, and hemoptysis, intrapulmonary hemorrhage, you can control with medication. And the other thing why rebiopsy should be questioned is, well, do you have a good pathologist? That is the most important thing. The misinterpretation of the biopsy results sometimes is a problem. And there is another problem. Did I take biopsy from the right region of the tumor? Well, the other reason for misinterpretation of the biopsy results is either intratumor or intermetastatic heterogeneity. First, if there is intratumor heterogeneity, there are different areas of the same tumor with different genetic profiles. So who is guaranteeing me that I took the biopsy from the proper place? And also, if we are taking biopsy from the metastases, there are differences in genetic profiles between primary tumor and metastases. Don't forget, metastases are the best, most viable cancer cells who were made to avoid all immune system. So the genetic profile from the metastases can be different from the genetic profile of the primary tumor. Well, there is, of course, circulating tumor DNA. That is another way to get the information for the tumor progression. The ctDNA is a tumor DNA that has been shed into the bloodstream, and it can be present in 0.01% up to 90% of the total cell-free DNA. And the amount of ctDNA is related to the tumor burden and varies between patients with different clinical presentation. Of course, the best thing especially for this T790M mutation, is to get plasma. If the patient is positive, T790M positive, okay, we can proceed to treatment without tissue biopsy. But negative result doesn't mean that this T790M mutation is absent. Any negative or inconclusive result with plasma should be confirmed by a reflex tumor biopsy when feasible and as soon as possible. Why are inconclusive results present at ctDNA testing? First, tumor heterogeneity, poor tumor cellularity, insufficient tumor DNA present in a sample. Then there is assay-related factors, low test sensitivity, poor pre-analytical preparation and processing, hardware or software failure, and there are some factors regarding the tumor itself. First, prior chemotherapy killed all the cells and all cells with that mutation. Second, there is tumor heterogeneity already mentioned, or there is a lack of ctDNA shed. Multiple factors. There are some tumors that do not shed or shed tumor DNA in very low quantities into the bloodstream. So the location and that DNA shedding depends on location and the size of the primary tumor, number and location of metastatic sites, vascularity of the lesion, overall tumor burden, advanced versus early stage disease, and sometimes a negative plasma test result due to absence of tumor ctDNA may be recognized by the failure of the test to detecting other driver mutations. So the test will, that ctDNA will not tell you if the tumor changed from adenocarcinoma to a small cell lung cancer. So these are the limitations of the test of ctDNA testing. First, tumor heterogeneity, then false positive results are very rare. They are possible given the small amounts of DNA normally available in blood sample as compared with tissue. And T790M negatives on blood assay will require biopsy. There is 30% false negative rate of plasma genotyping. And these patients still need tumor biopsy to determine presence or absence of T790M. And this is the scheme for plasma testing. Actually, if there is a patient with T790M positive mutation in plasma, we will skip biopsy and start third generation GFR tyrosine kinase inhibitors in all negative patients. Whenever possible, we have to do the biopsy. And it is all present in the clinical trials. And T790M on disease progression in Serbia, we have tests performed in Serbia. And this is our study from Serbia, that actually we have 64 patients progressed on first line of therapy with tyrosine kinase inhibitors. And positivity rate for plasma was only 28%. And biopsy positivity rate from tissue was almost twice more, 54%. So actually, if you have plasma positivity, you can proceed with third generation tyrosine kinase inhibitors. But if you have negative results, as whenever possible, we need to do the rebiopsy. And these are the challenges. For costs, availability, test choice, and time to results. Then sometimes, especially in low-income countries, integration of molecular testing into routine clinical practice can be hardly achievable goal. Then the knowledge to do, when to do, how to do, when to perform, the proper timing, the proper choice of lesion, and tumor tissue sample adequacy can be a problem when we are determining the candidates for next generation therapy. And the point is, we all need to have proper training to do these rebiopsies. Don't forget, we are doing rebiopsies in cancer, proved cancer patients, with all the consequences of these rebiopsies. First, there are delusions for patients and for the doctors that there are some problems which are not really real. First, patients and doctors sometimes think they are not willing to undergo rebiopsy disease progression. And that is the delusion that actually patients are not really willing to do the rebiopsy disease progression. Well, that 90% of the patients in all studies are actually willing to undergo rebiopsy disease progression. I can say it from my personal experience. Patients with lung cancer who are candidates for rebiopsy, in more than 90% of my cases, they will give the consent to do the rebiopsy. Adverse events of rebiopsy on disease progression are the only concern that both doctors and patients need to think about. But we are all we can, as we are doing in our routine bronchoscopies, to practically to make these adverse events at the lowest possible level. And insufficient tissue quantity and quality for therapy decision is another delusion, that we had insufficient tissue in only 14% of the patients. So practically 86% of the patients, both in our experience and in international studies, major international studies, had insufficient tissue for treatment decision. So these are all delusions that we have to fight with, because it's for the good of our patients. At the end, I would like to conclude that rebiopsies give more information than just this mutation for the third generation tyrosine kinase inhibitors. They have to be performed whenever clinically possible and meaningful. They are feasible. They are safe if we take care of usual indications and contraindications for bronchoscopy. They require cooperation of pulmonologists, bronchoscopists, of course, and the patient in the first place. We have to do rebiopsy on progressive lesions, not on stable disease. And if the ctDNA testing is available, we need to do it first and rebiopsy later or at the same time, if possible. But this is kind of our wish, that ctDNA and rebiopsies are actually complementary methods. And we have to take care about tumor heterogeneity, both intratumor heterogeneity and intermetastatic heterogeneity. Thank you very much for your attention.